It's my pleasure to welcome and introduce Dr. Karen Hicklin, who came here from the University of Florida in Gainesville. Dr. Hicklin got her PhD at NC State University in Industrial Engineering. She then received a very prestigious postdoctoral fellowship at the University of North Carolina, and today she's going to talk to us about assessing the impact of multicomponent interventions on CRC or colorectal cancer screening using simulation. Thank you very much, Karen.
Thank you. Yes, we have the mic on. Thank you for that introduction. And as was just mentioned, I'm going to talk about colorectal cancer screening and different interventions that we were able to model within a simulation. But before I get there, I wanted to talk a little bit more about my path, which was also maybe expressed just now too, but I just want to talk about it because it kind of really transformed how I thought about my career. So I received my Bachelor's of Science in Mathematics from Spelman College, and from there I went to Georgetown and I received my Master's in Applied Mathematics and Statistics. From there, I was able to go to NC State, and that's where I was introduced to industrial engineering. I kind of knew about industrial engineering beforehand, of course, hence why I applied and thinking that I would like that as a career field, but I didn't know a lot about industrial engineering. But what ended up happening was my transition from math at Georgetown to industrial engineering actually really was beneficial for me. After that, I completed 2 postdocs. One was in the Department of Statistics and Operations Research, and the second one was in the Department of Health Behavior within the School of Global Public Health at UNC. So that kind of gives some sense of where I've been, and currently I'm an assistant professor at the University of Florida. So the work I'm going to talk about today is really collaborative work. It started when I was a PhD student, and it incorporates researchers from UNC School of Public Health. We have folks from NC State, ISE, as well as Oregon Health and Sciences University, as well as the CDC. So this is very collaborative work. Some people work more on the stakeholder side, and some folks work more on the modeling side. And this model that I'm going to speak about today has been used in various settings. I'm going to talk about it in the setting of North Carolina, but it's also been, a version of this model has also been used in Oregon to look at colorectal cancer screening. So just to give a little bit of a background within this particular cancer. So colorectal cancer is any cancer that affects the colon or rectum. And then we have a figure on the right that kind of displays the areas of the body that we're talking about. So the colon is going to be the large intestine or large bowel, and the rectum is the passageway that's going to connect the colon to the anus. And then when we talk about our screening mechanisms, what we're really trying to do is figure out if we can pick up or detect growths, abnormal growths, or what we may consider to be polyps. And these things can form in the colon or rectum, and if they aren't removed or detected or treated, then they can turn into cancer. And so we also know that routine screening can be used to detect these polyps and then ultimately have them safely removed. In terms of the burden of colorectal cancer, it's ranked 4th in terms of incidence of cancer. In 2019, it had over 142,000 new cases. In terms of mortality, it's also ranked 4th, and we see that that resulted in about 51,000 case deaths in 2019. And in terms of the economic impact, there's a lot of money, medical costs, spent within colorectal cancer care at about $14 billion. When we talk about screening of colorectal cancer, there are different modalities and there are different standards that are in place. First of all, it was established more recently, probably within about a year or so, that the age for screening should be between 45 and 75. When this model was developed and built, the age was 50 to 75. But new evidence has come out to suggest that screening should start at an earlier age, and it should also start at an earlier age for different subgroup populations, which we'll talk about different subgroup populations a little bit later. We know that screening is effective in reducing colorectal cancer morbidity as well as mortality. If we are able to catch cancer early, we know that the survivability is much higher, And we also know that treatment is going to work best when you catch colorectal cancer early. There are different screening modalities. We're going to talk about two in particular, but I wanted to outline just a few others that are being considered. There are stool tests, and these tests allow you to be what we consider to be up to date in terms of being screened for 1 to 3 years. You have flexible sigmoidoscopies, and these allow you to be up to date within 5 years or 10 years, and it depends on the combination of other tests that you may do in addition to that. You have a colonoscopy, which allows you to be up to date for 10 years, and then you have what's considered to be a virtual colonoscopy, which we don't really get into that much, and that allows you to be up to date for 5 years. And all of these things, all these modalities are prescriptive to patients just based on their history, maybe some things that are found. For instance, someone may get a colonoscopy in 1 year, but would be recommended to get a colonoscopy maybe in 2 more years because there was something that was found but not big enough or not at the point where it needed to be removed, but there was just something that was abnormal about this screen. I wanted to compare just two of these modalities because these are the two modalities that we really focus in on. And this is going to be colonoscopy and the FIT. In terms of screening interval, every 10 years is when you would do a colonoscopy. The FIT is something that you do every year. The cost is much higher for a colonoscopy as compared to a FIT. The convenience between these two is that the colonoscopy is going to be more invasive. It requires bowel preparation. It requires about a day's worth of preparation before you're actually able to receive the procedure. And then a FIT is something that you can take pretty much at any time. You can take it at home. You can take it in clinic. It's more convenient in that setting. In that sense. The colonoscopy is going to provide higher accuracy, and the FIT also is associated with false positives. If you receive a false positive or if you receive a positive FIT, you then have to go for a diagnostic test, which is going to be a colonoscopy anyway. So some people are getting colonoscopies when they don't need them because of this higher rate of false positives. In terms of complications, they're more associated with an invasive exam. So that would be the colonoscopy. There's the risk of bleeding. There's the risk of tearing. These are things that can result from a colonoscopy. A FIT doesn't have risk in the same way. And in terms of the follow-up from the diagnostic, if you sense something abnormal within a colonoscopy, you can remove those polyps during the exam. So that's a benefit. You're already there, and they can do certain procedures to get rid of some of those problematic polyps. Before a FIT, it's really just a test to detect if something is an issue, and if it is, then you have to follow up with a colonoscopy, and then they go from there in terms of maybe removing polyps if needed. I don't really have to address this component of the presentation to you, but this is just outlining different benefits of simulation. So this work is going to use a micro simulation, which is just an agent-based simulation model, and we're able to project the impact of different policies in our environment or in our population on colorectal cancer screening and different outcomes. So that's a major benefit that we have within this particular methodology. We're able to also identify which strategies are going to be cost effective. The perspective or this part one of this research is really focusing on the effectiveness component, but the cost-effective strategy is really something that is important within population health that we want to look into a little bit more. It measures the impact on existing health disparities. A large part of this work is looking at subgroup populations and what interventions are impactful for different groups. So we want to see what's best for the overall population, but then we have different characteristics of populations that are going to see benefits differently. And we want to see how that can be realized within this simulation. And then we're also able to inform decision makers and policymakers around how to strategize and how to promote different programming within their certain settings. There are two targets that we focus on in this particular model. So in 2020, we wanted to be able to reach this target of 70.5%. And this was established by Healthy People 2020. And they had suggested that by 2020, the colorectal cancer screening rate should be about 70.5%. That number has since increased. So now the goal for Healthy People 2030 is to be 74.4% by 2030. So even though that is the new number, the number I'm going to be focusing on is the initial number, just given the point in time in which this study was done. That's the first target. The second target is a more ambitious target. And this target says that they wanted 80% of the population to be screened by 2018. And this was established by the National Colorectal Cancer Roundtable. And given this ambitious target, it wasn't reached in 2018, but now the goal is not necessarily defined just by a year, but it's saying they want 80% in every community. So therefore, it's saying that the goal is always going to be 80% screening. And we know that there's many benefits to screening. Therefore, we're trying to see what are the approaches that can be used to get to these different targets. So the motivation behind this problem is really given these two targets and trying to figure out how we can get there. We know that current strategies or usual care as it is now or as it was when we were doing this study would not get to those targets because they were far from those targets. And so we wanted to be able to say, how can we get there and what strategies can we use to get there? We know that additional efforts will be needed to reach the overall population as well as the subgroup populations because there are other additional barriers that exist within different communities, and such as accessing care. This could be within low-income, underinsured, or uninsured patients. And we wanted to also look at if we are able to identify the different outcomes, we know that there can be different combinations of interventions that can be used to get to these targets. And this is a body of literature that we consulted to see what are the more impactful multi-component interventions that we can apply in our modeling structure to see how it would do within North Carolina. So the research question that I've kind of alluded to is really focused on how do we reach these goals within a 5-year intervention time frame. So we would say that we wanted to start the intervention on January 1st, 2020, and we wanted to see how likely are these multi-component interventions and how likely will they be able to increase the screening rates to our targets within 5 years. So by 2024, how well could we do? And of those interventions that can reach those targets within that time frame, how well do they do in historically underserved populations? And so we also look at different key subgroups that are defined by race, ethnicity, and insurance status. So now we're going to get into the model. So this is a micro-simulation, and it's of the entire North Carolina population. It uses a synthetic population or a simulated population based on information from the American Community Survey. And this particular study or this particular population is derived or generated from RTI, and they are in North Carolina. So they're able to predict out a population of people that can be used in a virtual setting. So that's what we were doing for North Carolina. So it's a realistic population of all individuals who are going to be eligible for colorectal cancer screening during our intervention window. We model the natural history of each person, meaning that we're modeling just their life course. So it's a from birth to death model, and there's a particular time period that we focus in on, and that's going to be when someone turns 50. So when they turn 50, between 50 and 75 is kind of when we implement these interventions within the model to see how their behavior will change, but it does model from birth all the way to death according to different statistical models. We look at routine screening and diagnostic testing and different screening habits. So the model also allows for, since it's from birth to death of different populations, it allows for polyps to grow over time, and then once they become detectable, then our model is able to see that it's of a certain size, and it can say whether this person, whether this cancer can be caught early or whether the polyp can be removed and things of that nature. We test out 2 different modalities. We test out the FIT and the colonoscopy, and then in terms of compliance, we're looking to see how will people adhere to different screening guidelines, and we believe that these interventions will be able to get us to having more people adhere to these guidelines. The model is made up of 3 distinct characteristics. So we look at demography first, which is going to be the makeup of the population. This is using the census data, and we're able to project out this population of people. So we have the people in our model, and they go, we have the characteristics of the people, and that goes into our model. The second piece is being the natural history component. So it uses the RTI natural history of adenomas and cancer model, and that's incorporated into the model in addition to being able to check and calibrate our model with the cancer registry in North Carolina to make sure that cancer cases are matching. So essentially how we use that is we identify how many cancer cases are in reality or how many cancer cases have happened in reality. We want to match that number as much as possible in our model by calibrating the natural history parameters of polyp growth. So we make sure that we understand how fast or how slow polyps should grow over time in order to reach that cancer registry number as much as possible. So that's the calibration that we do within the model. The last piece, which is where I'm going to really focus in on today, is around the screening and the testing. So this is using information from claims data to develop these statistical models. Those go into our model in terms of being able to predict out certain probabilities. The second piece of that is the intervention scenarios. How do you craft these interventions? And we looked at different literature sources to be able to identify evidence-based approaches for interventions within a setting similar to our setting. So as you can imagine, people do a lot of clinical trials. They're able to test out different interventions within their communities. But what we needed to do was we needed to make sure that the community that they tested out their intervention in matched the community that we're testing our interventions in, which is just the state of North Carolina. So we had to match on certain elements of their characteristics within their population that could be applied to North Carolina. So within that, we were able to then craft different intervention scenarios or approaches to be able to increase screening compliance. So all these things feed into this North Carolina colorectal cancer simulation model, and we're able to identify how these different interventions are going to be impactful. When it comes to the modality and screening compliance, we have different statistical models that tell patients what kind of modality they will have. So essentially, in the model, we are able to, with some probability, predict the modality. And so everyone has a certain modality associated with them. To make things simple, we let them keep that modality. So they do not switch that modality, but I will talk about how we had to do some of that in our model after we determined what our interventions would be. But if you are a colonoscopy person in the model, you remain colonoscopy in the model. If you're a fit person, you remain a fit person. We also use statistical analysis based on claims data to be able to identify who would be what modality in addition to how well someone would comply. So there's a certain probability that even though we know your modality, we know that you're either a fit or colonoscopy person, there's still some probability that you'll actually complete the screen. So we use historical data to be able to inform that. In terms of our multi-component interventions, we look at certain different approaches. So multi-component interventions are typically bucketed into three different areas. We have increasing provider delivery, increasing demand, and increasing access. And a multi-component intervention is going to be an intervention that aims at doing some of these things, but not siloed. You have to be doing them in combination, and they have to come from different areas. Unless they are increasing access, I believe you can have multiple aspects within increasing access, but in terms of the other aspects, you have to go from a couple of different components from each bucket, and that constitutes a multi-component intervention, which differs from a single component intervention, which would literally just be an objective of just one of these options. So when you combine them together, that's what we consider to be multi-component. So how were we able to identify the different interventions that we wanted to use? So there are so many different interventions that are out there different communities are implementing these interventions. But as I mentioned before, we needed to make sure that our interventions matched our population. We also wanted to consider interventions that were different, that they had different aspects to them. And we wanted to be able to show this because stakeholders have different needs. There are some stakeholders who will be more willing to invest in a FIT intervention than they would in a colonoscopy intervention. And then you also have some clinics who are more so interested in the academic perspective of screening, so making sure that their clinicians are at a certain rate for screening than on the patient side. So we wanted to weigh all of these different options in terms of developing our scenarios. The last piece we consider are what we would be like these go big scenarios, in the sense that we wanted to see which interventions had the most power in being able to increase their screening rate. So we looked at several different sources of literature to be able to identify what our multi-component interventions would be for the study. So we developed 4 different interventions for this study. The first one is a FIT favoring intervention, and the FIT is a fecal test, and that allows people to be up to date for 1 year. This is primarily done in care clinics, so all patients who receive care within that clinic could be eligible. It incorporates different aspects, so it has a mailed FIT program, patient navigation, patient reminders, and provider reminders. That's what makes it multi-component. We also report out the average relative risk among the different studies that included this particular structure of multi-component intervention. The second intervention was a colonoscopy favoring one. So now we're getting at a different type of modality. So this one also has patient navigation, but it's colonoscopy focused, whereas they are patient navigators trying to get people to screen more so with colonoscopy. It also includes provider reminders, one-on-one education, as well as mailed education, and client reminders. The third one is provider assessment and feedback. So this will be more so on the clinician side, and it also includes other elements like patient navigation, reminders from the provider and client perspective. The last intervention has a different targeted population because it's for Medicaid enrollees. So this would be similar to the first intervention, which is FIT favoring. So it's a mailed FIT program. It includes patient navigation, but it's only for those who are eligible for Medicaid. So if we're looking at that column that has the relative risk for the different interventions, we can see automatically that colonoscopy favoring intervention has the highest, and the lowest one is provider assessment and feedback. And I want to talk about that a little bit more. So when we initially identified our interventions, we wanted interventions that had the most power in terms of increasing screening. So that provider assessment and feedback did not have a high rate or a high relative risk in terms of increasing screening. However, in terms of being impactful within clinic, this is something that's well received. In fact, the CDC has a lot of clinics that they have invested in to be able to implement this type of strategy and this type of program. So our collaborators at the CDC wanted to see this one implemented within our study. Yeah, so it increases compliance. Yeah. Yeah, so you're like 47% more like higher to screen if you were to get the provider assessment and feedback intervention. But the other ones double or triple the impact of compliance within those studies. Yeah. Mm-hmm. Yeah. Oh, was there another question? I should probably pause. Okay, I'll continue to go on, but certainly feel free to stop me. So within our model, we're doing this for the entire state of North Carolina. And so we had to identify different reach parameters because we couldn't just do it for the entire state. So we wanted to identify what would happen if we were able to reach different percentages of the state. So we started with 25%, we did a 50%, 75%, and 100% reach. And the 100% reach is the one that's not realistic, but it just tells us how well we could do. Like, this is the best that we could ever do in our population. if we were able to implement it. And reach just means the amount of people who get the amount of people who are offered the intervention. That's how we define reach. The population are going to be North Carolina residents, 50 to 75 years old, within this particular time window. We look at different insurance makeups. So we look at private insurance, Medicaid, and Medicare. We also look at a particular portion of uninsured patients who receive their care from federally qualified health centers, and that makes up about 51.4% of the North Carolina uninsured population. So we were able to include them in our model. And for the fit favoring for Medicaid scenario, we only looked at ages 50 to 64 when people would have Medicaid. And we also hypothetically looked at this point in time, was with and without Medicaid expansion, because at that point, North Carolina did not expand Medicaid. So in total, we had about 32 scenarios. Now, I wanted to get into some of the changes that we had to make to the model, because as I mentioned before, if you were a fit person, then you remained fit. If you're a colonoscopy person, you remain colonoscopy. But our interventions needed some crossover, because we had one intervention that was fit favoring, meaning that we were pushing fit. Then we had another intervention that was colonoscopy favoring, so we were pushing colonoscopy. So we had to change modality for certain patients in our model to accommodate our intervention. So this next figure here outlines some of the things that we had to do within our model. And it takes it from the perspective of the colonoscopy patients. And another assumption for our model is that even though a colonoscopy allows you to be up to date for 10 years, in our model we allow for a colonoscopy to be given every 5 years. And the reason why this is done is because in reality, if you are eligible for colonoscopy, say age 50, you may get your colonoscopy at age 50, or you may wait to age 51 or 52. But we don't model every year the option for colonoscopy. So overall, the major assumption is that we give it an opportunity every 5 years. So in reality, although you may have an opportunity every year, in our model, we do it every 5 years. But once you get the colonoscopy, you're up to date for 10 years. So just to point out what's happening here in this figure, so we have people who are before the intervention, they all are colonoscopy. And then when the intervention occurs, if they are a colonoscopy person and they get their colonoscopy, then they remain colonoscopy throughout the intervention. If they do not get their colonoscopy in the first year of intervention, they become a fit person. They remain a fit person until they're eligible for their next colonoscopy, which in this case would be after the intervention is complete. We needed to do this because if you take someone from being a colonoscopy person and making them a fit person just for that 1 year in the model, it was not accounting for the fact that they are still not up to date as they would have been had they gotten their colonoscopy. So we needed to give them an opportunity to be up to date every year by offering them a fit every year until their next eligible date for colonoscopy. So this is just a change in modality that we had to do within our model to accommodate our intervention. So now we're going to get more into the specifics of the analysis as well as the results. So we were able to simulate all of these interventions under our different scenarios and for our different reach parameters. And we were also able to look at the state overall in addition to these different demographic subgroups. This particular program runs in AnyLogic. It runs on a Linux machine. We have different metrics here in terms of the cores and gigabytes and things of that nature. And it takes about 24 hours to run with about 20 replications. For our model, as I mentioned before, we're looking at a synthetic population, and this synthetic population was developed at a certain time period. So we had to age people in that, or we had to figure out how old people would be in the year that we were interested in, and we pulled the population that we needed. So we were looking for people who would be 50 to 75 in 2020. Therefore, we needed people who would be 39 to 64 in 2009. So we wanted people who were aging into our model. And actually, this is just the beginning part. We also needed to have people who will be aging out, so people who would be turning, so in 2025, which is the end of the simulation, we needed people who would be turning, getting out of that age range. So we included all of the ages that would be needed, who will be eligible for screening in 2020, between 50 and 75 years of age. So now we're going to talk about the results. So the first table that we typically try to present is just going to be a breakdown of the different demographics. So the first line is going to be the overall population, and these are people who, this is not the entire population, but it's people who would have been eligible for screening, so our 50 to 75-year-olds. And then we have everything broken down in terms of demographics. We have gender, race, ethnicity, urban versus rural. We have different age categories, and then we have insurance types. So we see in our study, most of the population, or majority of the population, is white, female, non-Hispanic, lives in an urban environment. And at the beginning of our simulation, most of the people were above 65. At the end of the simulation, they're also above 65 as well. So we have the column of starting before the intervention, and then looking at after the intervention, the different breakdown in subgroup populations. And most of the population actually has private insurance, and we see more people shifting from into this bucket here, this Medicare bucket, and that's mainly because our population was aging, so we have more people who will be eligible for Medicare at that point. So now we have a figure that outlines the percent that's up to date in 1 year of intervention compared to after 5 years of intervention without Medicaid expansion and with Medicaid expansion. So the column on the left is going to be without Medicaid expansion. The column on the right is with Medicaid expansion. The top row is going to be after 1 year of intervention, and then the bottom row is after 5 years of intervention. And what we can take away from the comparison of these screens is that every intervention had an impact on screening, but some interventions were better at increasing screening rates. In particular, this group, this cluster here, which represents the 25, 50, 75, and 100% reach, is going to be impactful within only 1 year. So it was able to reach our initial goal of 70.5%, and I'm just talking about the 100% reach case, but it was able to reach that, and it got close to our second target, which is the solid line of 80%. The colonoscopy intervention gets close to 70.5 after 1 year, but doesn't quite reach it. But what we see as a difference after 5 years is that this colonoscopy intervention exceeds 70.5 as well as 80.5. And in fact, even at 75% reach, it also is able to get to 80%. And the intervention for FIT has a similar chart here as it does here. So it reaches at 100% reach, crosses over the 70.5% threshold as well as it did after the first year. And this is mainly because the FIT program is a yearly thing. So you do it every year. And it doesn't have a lasting effect beyond that year. So you would, in order to increase your screening for FIT, people who screened in previous years have to continuously do it every year. However, with the colonoscopy intervention, we notice between the first year and the 5th year, there's a lasting impact because you're up to date for 10 years. So regardless of when you get screened, you're still considered to be up to date for a longer time period than you would be with the FIT case. The Medicaid versus no Medicaid case just shows slightly more in terms of reaching our targets. It actually had the most benefit within the FIT for Medicaid population, which I don't really talk about too much even in the subsequent slides. But I wanted to give you an overview of this. So now we're going to talk about what happens in subgroup populations. So we have the first slide here is going to be for 25% reach. And we have the different characteristics broken down for the subgroup populations. We have all of the different interventions, and we're comparing them to usual care. The pluses is just going to be the increase of percentage points from our usual care case. It may not be very easy to see, but numbers that are bold are going to represent those populations that reach our first target of 70.5%. Our second target of 80% will have bold with a little hat or caret symbol. So in this example, we see that at 25% reach, that the colonoscopy intervention is able to get over that first target of 70.5 for folks that are over 65, people who have private insurance, as well as Medicare. The next one here is going to be 50% reach. So this is reaching about half of the state at this point. And we see that there is more of an impact when doing this. The colonoscopy intervention, of course, we see more bold here. We also see this particular group, which is private insurance, being able to reach that 80% target. And now we see this private insurance group within the mailed fit program able to reach the first target of 70.5. I haven't really spoken a lot about mailed fit or provider assessment and feedback, mainly because these two interventions up here are going to be the most impactful for the overall population. However, every intervention has had an impact or does impact screening rates. The next one here is going to be 75% reach. And now, in addition to colonoscopy being impactful for the overall population, so is the mailed fit program. We also see different subgroup populations as female, white here, urban, and then we also have the older group within our study, as well as private and Medicare insurance being able to reach our initial target. And then we just see that the colonoscopy intervention also is able to reach the 80% reach for different subgroup populations as well, as noted by the caret symbol. This last one is how well we can do overall. This is the best that we could ever do if we were to reach every single person who is eligible for screening. And so what we see here is that the FIT program does get to that 80% mark, but it only does that in one subgroup population, and that's for those who have private insurance. The subgroup populations, there are a lot more subgroup populations for the colonoscopy intervention that's able to reach that ambitious 80% goal, and that's the intervention that we look at a lot because of its lasting impact and its lasting effect. The other thing I want to point out is down here for this intervention, the Medicaid intervention, it has the most impact for Medicaid populations. And in fact, at 100% reach in our model, given Medicaid expansion, that this particular intervention actually does reach the 70.5% target. So that was actually promising to see, given the fact that if we were able to expand, or at that point, if we were able to expand Medicaid in North Carolina, then there will be an opportunity to actually really increase screening in a population that typically or has historically been underscreened. The next thing we wanted to do is compare our two interventions that had the biggest impact in our model. So this would be the mailed fit program and the colonoscopy program. And we wanted to see the impact of reach and relative risk on increases in the percent up to date. And so what we see with the figure on the left, this is for the mailed fit program, is that we have different increases of relative risk as well as different increases of reach, and that kind of grows linearly. For the colonoscopy one, we don't see it as the same trend, but what we see is that you don't really need a very high relative risk to be impactful within this. So for the mailed fit program, if you have a low relative risk, you can expect lower outcomes. But for the colonoscopy intervention, your intervention really does not have to be that high or that impactful in terms of relative risk of increasing the amount of people who would screen. You just need a little bit better, and you need to incorporate colonoscopy as a part of your intervention to be able to reach these targets. So we were able to do this analysis just to compare these two interventions. The other metrics that we were interested in dealt with colorectal cancer cases as well as deaths. So every intervention, for the most part, is able to reduce cases as well as deaths. And we also have it broken down by stage. And as you can imagine, as you increase reach, you also increase the amount of the differences in death. So this is for 25% reach and 50% reach. And then we also have it for 75% reach and 100% reach. So in summary, this particular study showed that we can use these different interventions to possibly reach our screening targets at different population levels, at the overall population as well as within certain subgroup populations. We noticed that the colonoscopy favoring intervention was the most impactful, but this is also due to the lingering effect of the colonoscopy. But we also realized that there's a trade-off between when you would use a colonoscopy versus not, given the fact that it's, as I've mentioned before, it's a little bit more invasive, it's much more expensive, takes a lot more prep for it. So a fit may be better in certain settings. So at this point, we need to actually look into see what will be the most cost-effective strategy instead of just what's the most impactful strategy. We were able to look at these different targets conditional on different levels of reach. And what we have learned in talking to stakeholders is that 100% reach, of course, is just not, I don't want to say it's impossible, but it's not realistic. It's not as attainable. But say somewhere between 25 and 50 would probably be where we would able to really have some impact within North Carolina. So certain strategies have to be implemented to be able to do that. And we also know that it's not just one approach for every person, and some approaches are going to be a little bit better within certain communities. And I already talked about this cost effectiveness part of the overall population. And then also we need to look into how we can eliminate potential issues when it comes to disparities in screening by being able to incorporate different combinations of interventions. This is the last slide for this. I did want to just touch on, since I probably have like a little bit more time, I just wanted to touch on just a couple of other projects that we are looking into within this area. And I typically try to think about it in terms of this data-driven approaches to improve healthcare quality. So a lot of my research can be broken down into different buckets. The smallest bucket is engineering education, which I have not done a lot with, but that is also something that's really important to me. But in medical decision-making, I have done some work within mode of delivery decision-making. So this is more about stochastic modeling and looking at trade-offs between when a woman needs a C-section while in labor. To expand upon that, we're also looking at not just a failure to progress diagnosis, but also looking at fetal heart rate tracings and different patterns that you can see within when women are in labor hooked up to monitors. The baby's heart rate is monitored, and we're trying to look into see if you can recognize certain patterns early on, whether that patient would be candidate for delivery somewhat immediately through C-section in order to avoid some type of brain injury or lack of oxygen to the fetus. I've also done some work in allocating incentives for testing for HIV as well as treatment, and then also some decision trends using web scraping across for uterine fibroids treatments. So just looking at the decisions that exist there. Within engineering education, this is a study that was done at the University of Florida, just evaluating the experiences of Black engineering students within the University of Florida using photo voice. So that's where we gave cameras to students, and they were able to go out according to some type of prompt, and they were able to take pictures. Then they came back into a setting. We did some individual interviews. We also did a group setting where they were able to talk through the pictures and kind of come away with some themes. And a bigger body of work for me currently is dealing with health disparities. So this is more on the population health side, the study that I just presented now looks at the impact of colorectal cancer interventions for screening. We're also getting a little bit more into the health disparities around that. Also looking into social determinants of health and how it impacts severe maternal morbidity and mortality. There's some work looking at genetic testing practices for patients who are diagnosed with breast, ovarian, and pancreatic cancer. There's a genetic tie to some of those cancers. We're also looking at the analysis of critical care resources within COVID-19 and how that may have led to certain disparities in mortality over time, and how do you evaluate who gets what resource, how do you prioritize certain patients in that setting. And then also done some work in evaluating different disparities in appointment scheduling and the impact of wait times. And of course, you have increased wait times that could lead to other issues sequentially in the future. So I just wanted to give that overall view of some of my research projects, since I was able to only talk about one thing today. But that's pretty much it, and I'll take any questions if you have them.
Thank you, Karen. So any questions? We have time for a few questions.
Actually, this is just a naive question. Excuse me, and I think Gabrielle asked it, but could you explain exactly what you say relative risk in this context, what that means? It's associated with a particular intervention, right?
Yeah, so in clinical trials or in the studies that we looked at, they report out relative risk in the sense that they are comparing the outcomes for usual care versus the outcomes for the intervention. And when they're able to do that ratio or comparison, they're able to say which intervention has can increase a particular outcome. So our outcome of interest was increasing screening. So a relative risk of 3.78 for that colonoscopy intervention is essentially saying that you are 3.78 times more likely to screen with that intervention than you would be otherwise with nothing, like compared to usual care.
All right, excellent. Thank you. And then do these things, how do they, suppose you do multiple interventions, do you add how do you sort of account for that, the fact that those might not necessarily be additive in terms of the likelihood or things like that? Or is that a big issue if you're doing multiple interventions?
I think that's a big issue for folks who want to take this information from clinical trials or from literature and put it into models. It's certainly an issue in trying to figure out what is the correct combination of understanding the impact overall. I think for us, what we, in this, I don't know if this was the best approach either, because we looked at different studies and they all had different relative risk values. So we just took the average. That may not necessarily be the best approach, but we wanted to just get at what value would be representative. But if they are different components and you're taking those different components siloed and putting them together, I think that's a bigger question that I'm not really sure. Luckily, a lot of the interventions had those components already embedded, so we were able to report out what that would be. But if you take a lot of single component interventions and you add them up, is adding the correct thing, is maybe multiplying or developing a function given the proportion of impact that it has on the outcome. That may be a better strategy. So yeah, that's a great question.
Thank you. I have no other questions, at least right now. I can walk it over there too.
Yeah, I have a quick question regarding the simulation. I noticed the simulation take about 24 hours on a pretty powerful computer. So something like a computational intensive simulation. So where does those computational load come from?
Well, so I believe the population that we're modeling is really large. So we have everyone from birth to death, and even though we're capturing that 50 to 75-year-old block, it's still recording everyone from when they were born until when they die. And we're doing it for a lot of different cohort ages. And so it has to incorporate every possible thing that can happen based on that person for each population. And then we have all these replications. In addition to that, we had 4 different scenarios. And so it was doing the same thing, but taking the same population through different courses of action. So I believe that probably adds to some of it. I will admit I haven't gone too deep into what's actually making it, why it lasts so long or why it takes so long to run. But I believe it's just the amount of data that it needs.
So why should we simulate the problem in this way? Why not just build up a statistical model and just use the statistical model to predict population-wise what is the percentage people will take the screening?
Yeah, and actually that's a great point, because we do have some people who have done that. So that some people have taken just the important aspects of the model and been able to create a different model that runs much faster. And it uses certain components, but it erases everything else that's not needed. Because in this model that I'm using, it captures a lot of different outputs, and it does it according to individuals, it does it according to a population, it does it according to different agents. So there's a lot in the model that we don't necessarily always report out, so it could benefit from a smaller model. And so we have some people, a part of the team, who are working on that. Yeah.
Thank you.
Mm-hmm.
Hi, great talk. I was just curious. So usually people do not screen under the age of 50, and so that's why you only looked at 50 and above. However, overall in the U.S. in 2022, about 11% of colon cancers and 18% of rectal cancers are for young onset people, so people who get that below the age of 50. So, and by 2030, the numbers are supposed to like double. That's the projection. So do you have any plans to look at this age group or sometime? I was just curious.
Yeah. So that's actually something that we had been talking about before those guidelines were shifted. But yeah, we currently know that the age now is recommended to be 45. But what we believe is that the age is probably even younger for different subgroup populations. So overall, the age group is 45. So yes, we can incorporate that into our subsequent studies. But I think even more from that is just like targeting certain populations, or of course family history also plays a part, but we don't incorporate that either. So I think that it can benefit from using some of that. Mm-hmm. Yeah, great question. Thank you.
Questions? I had one quick question. I'm
Okay.
sorry. So I don't know. I'm not too familiar with agent-based simulation. This is something sort of you go to talks. So and you're also modeling natural history of each individual. So my question is, when you model natural history of an individual, say, or cancer development, does that include the interventions throughout their lifetime, or is that, or are you taking a cohort that hasn't had any interventions to model the natural history?
Yeah, so we use the same cohort for everything. So the same cohort is going to go through usual care, meaning that they just get care as usual, kind of similar to the first aspect, no interventions. The second cohort, the second scenario, I guess, they're going to go through, they're the same people, because we basically are using the same people and just trying to see what would the impact be on the same people. So that cohort goes through the model. Now we overlay our interventions to intercept their compliance. So in the usual care model, they have a compliance that is generated from statistical models, but then we overlay an intervention in addition to like some behavioral aspects, but we overlay that intervention and we increase their compliance if they adhere to, we increase their compliance and then we calculate who's up to date. And then we have another, in that one, that we get results from that. Then we have a third scenario and we send people through and then we overlay the different intervention on that one. So everyone starts off with no intervention and we just are compounding the intervention on top.
Thank you.
Yeah, thank you.
Any other questions? Well, let's thank the speaker one more time. Thank you, Karen, for coming.
Yeah, thank you for having me. I appreciate it.